Welcome for standing by. At this time, all participants are in listen-only mode until the Q&A session of today's conference. At that point, if you'd like to ask a question, you may press star followed by the number 1. This is being recorded. If you have any objections, you may disconnect at this point. Now, I'll turn the meeting over to your host, Kristen New. You may now begin.
Thank you, and good morning, everyone. Thank you for joining us for our December Midwest Quarterly Stroke webinar. We're thrilled to have representation from many states across the Midwest today, and also our guest speakers. I'm joined by my name is Renee Sanu, and I'm a senior director based in Illinois. Joined by my coworker Kathy Thomas, who's also a senior director covering Michigan. So we'll share the login instructions for this webinar. You both need to join via the URL that you received in your confirmation email from Kristen Matthew, and also to call in the audio portion. If you have any issues or you're unable to view the slides, please contact Kristen Matthew. Her email and phone number is there. Everybody should have received the slides in PDF form yesterday with your reminder email. The webinars are open to all professionals interested in improving stroke care, and this has included in the past, but it's not limited to nurses, stroke program coordinators, neurologists, program medical directors, and quality improvement personnel. We need to see this list grow, so again, we're thrilled to be able to share this information across the Midwest. The purpose is to engage in educational opportunities, to hear practices, to learn about barriers that are either specific to certain regions or can be applied across the Midwest and across the country. It's also a chance to network, and overall the goal is to improve stroke patient care. We see these for 1 hour on a quarterly basis, and we will be in touch with the next webinar. As part of the registration for the webinar, all of you were asked if you wanted to join an optional networking group. And the purpose is to create a list where individuals can connect with one another to network and share best practices. So if you'd like to join, feel free to email Kristen Matthew, and we currently have just over 300 participants. Displaying all of the ischemic stroke discharge population across the country, and the darker the blue, that's that there's a higher concentration of discharges that come from hospitals using Get With The Guidelines. So the purpose of this map is to show the representativeness of our national data when we're looking at Get With The Guidelines and reviewing data on a regional or national basis. The Midwest region, where just over 75% of the population is represented in your regional data through Get With The Guidelines. And we're going to take a look at some data in a moment. We're coming on the end of the calendar year, the end of 2018. So it means that we will begin reviewing Get With The Guidelines data for those hospitals that participate in our Get With The Guidelines stroke program. We will begin reviewing data at the beginning of April to determine qualifications for our Get With The Guidelines recognition program. So the data is due by the end of March, so we thought this would be a great opportunity to review instructions for checking your hospital's progress towards those words. And all of our team is available for continued consultation to help your hospital meet these achievement award levels, and please feel free to reach out to us anytime. And the deadline is the end of March. So when you're screenshots from reviewing your hospital's award progress, this on the upper left, this is what you'll see when you log in to Get With The Guidelines. And go ahead and click on that reports icon, and you click on configurable measure reports. Next slide gives you the step-by-step instructions for a report on those achievement measures, and are the measures that are most closely aligned with our evidence-based guidelines for optimal stroke patient outcomes. These are the measures that indicate if a participating hospital receives bronze, silver, or gold. And today I wanted to take a look at our progress as a region overall. Now, we don't award regions for our awards, but this is a great way to see how we're doing overall in the Midwest. And again, roughly 75 to 80% of all stroke population is presented in this benchmark group. You can see we meet the performance achievement level in all of the measures except for this first one. We're very close in patients arriving within 2 hours and then receiving treatment within 3 hours. So in the Midwest. And similarly, we have a set of quality, also known as our PLUS awards. So these are looking at additional measures. And these are the step-by-step instructions for checking your hospital's quality awards. In the West, we're also doing excellent here, meeting that 75% minimum required level in all of the measures, very close on the intensive statin therapy. So one of the measures. So again, great job in the Midwest. We're thrilled today to have guests from Michigan State University, and I'd like to hand this to my colleague Kathy Thomas to introduce Dr. Reeves and Michelle Fritz.
Okay. Great, thanks, Renee. Michelle Fritz is a trained epidemiologist and licensed vet tech with 12 years of experience managing clinical studies for both veterinary and human medicine. Currently, she is the project manager of Michigan Stroke Transitions Trial within the Department of Epidemiology and Biostatistics at Michigan State University. It has a strong interest in pragmatic research design and implementation that incorporates community-based research methodologies for improving patient and population health. She is very passionate about helping to bridge the gaps between research and clinical practice, especially as encouraged by the One Health approach. Matt Reeves is a professor in the Department of Epidemiology and Biostatistics at Michigan State University. His primary research interests center on issues of quality of care and outcomes in stroke patients using large-scale stroke registries such as the Michigan Coverdell Registry and the AHA's Get With a Guideline Stroke Program. His includes a PhD in epidemiology from the University of Pennsylvania, applied public health training from the CDC, and back in the day, a Doctor of Veterinary Surgery degree from the University of Liverpool in the UK. He authored over 200 peer-reviewed publications and teaches evidence-based medicine to CHM medical students and cardiovascular disease epidemiology and prevention to graduate students. He is a PI of the MIST study, a patient-centered outcomes research institute on the clinical trial testing the efficacy of home-based case management programs for a stroke patient, which is the topic of today's seminar. Michelle and Dr. Reeves, the floor is yours.
Thanks, Kathy, and good morning, everyone. As Kathy mentioned, we're here to talk about the Michigan Stroke Transitions Trial, which we'll refer to as MIST. Our work is funded by PCORI, and we don't have any additional disclosures to report. So we're going to review the challenges associated with stroke transitions, discuss the MIST study design and methodologies, present the MIST patient results. This work is currently unpublished, although it's been extensively reviewed during our final peer review process with PCORI. And then talk a little bit about reflections and offer you some resources that you can use in practice, and then happy to take questions at the end. Off with to think about the context of stroke. We know that stroke impacts many families, and of the approximately 1 million stroke patients discharged annually from the hospital, 70% of those survivors return home. And stroke is one of the leading causes of adult onset disability. I also know that for patients and caregivers, navigating that transition between the hospital and home is associated with substantial problems, including emotional challenges, social challenges, and health-related challenges. And we also know that stroke patients commonly encounter readmission rates, slow and complete functional recovery, poor rehabilitation care, unfunctional and informational needs, have patient adherence, experience dissatisfaction with care, and have limited access to post-discharge medical and community resources. Complex and challenging due to a couple of different things. First of all, servers are often multiple treatments, both for medications and different rehabilitation and nursing care. They have ongoing needs around comorbidities, education and information, role assessment, and community reintegration. They face challenges with lifestyle changes that are necessary for successful secondary stroke prevention, and often experience poor communication and coordinated care. From a based approach, there are challenges in that patients and families receive lots of great information from us, but often they're not able to process or retain that. And maybe that's due to the abrupt nature of stroke. This is a crisis event that occurs without warning and leaves people in a state of shock and confusion. In addition to that, we've certainly increased the hospital length of stay for survivors, and so there's a lot going on in a short period of time, and it just gives people a little time to absorb the information that they need to have a successful transition home. In addition to that, there's wide individual variation in stroke recovery that's determined by multiple different factors, including stroke severity, pre-stroke function, age, comorbidities, and social factors. And when discharge occurs, we send people to multiple different care settings, which could include inpatient rehabilitation, a skilled nursing facility, home health care, or nursing home or long-term care facility. At discharge, we have multiple different care settings. What happens is we often experience this halo effect where the care is delivered in distinct settings and it becomes fragmented across time, across these settings, and there's a loss of continuity. And it creates a challenge of knowing who's on first base. So we have multiple and diverse healthcare providers involved in the patient's care that are all coming potentially from different care settings. There be a lack of a central point of control and confusion not only among the patient of who's taking lead responsibility, but also between healthcare providers of who's charged for what and when. And ultimately, this results in poor communication and challenges for both the provider and the patient and their families. So over the years, potential solutions that have been to help solve the problems of transitions mostly focus around three primary mechanisms. One, to improve communication, often through e-health technologies. So looking at more effective ways to use electronic medical records, encouraging use of patient portals, using health information exchange systems, then offering in-home monitoring for patients. One of the other mechanisms is to improve self-management by providing access to information and education, finding ways to help activate the patient to become have an active role in their own health care, and then to teach disease management skills. And then the third is to concentrate on providing case management programs that can be delivered by healthcare professionals, including nurses, community workers, and peer coaches, or social workers. And again, this is all on improving self-management and coordinating care across settings. These despite these mechanisms, there's a gap in terms of what we know works best for whom and when and how. And so lots of questions still about effectiveness. So, which stands for the Patient-Centered Outcomes Research Institute, is an organization that was funded as part of the Affordable Care Act to fund research projects that look at patient-centered care and shared decision-making. And they have a big emphasis on involving stakeholders in the research process, an overall goal of having greater involvement of patients and caregivers, common and important clinical decisions. Quarterly focused on improving transitional care across different conditions and different time points. And there's a group of about 25 studies that were funded under this mechanism to try to tease out and understand how it can address and improve transitional care. It was one of those funded transitional care projects. So this was a project that was from October 2014 through March of this year. And as mentioned, Dr. Reeves here is the primary investigator of this trial. So the overall timeline for this study was we began with a development phase in 2015 where we interacted with patients and caregivers to better understand their experiences and help advise the development of our study. And from January 2016 through last November, we entered into and conducted a randomized clinical trial. We're currently still in analysis and dissemination phase, and I just want to point out that in accordance with PCORI's philosophy, we had an advisory board that had patients and caregivers as well as different health professionals that were guiding us along the way with this project. Pragmatic, randomized, open clinical trial that is a three-group parallel design to compare Group 1, individual care after people discharge home, to social case management program. And it was a combination of the social work case management program plus access to a virtual stroke support portal, which is essentially a curated online website to help support patients. So we stratified randomization by 3 recruitment hospitals in the mid-Michigan area, and we collected data at 7 days and 90 days after people discharged home, and this was done through a telephone interview. To emphasize how the groups work. So after acute stroke and after people returned home, they were randomized at the point of discharge home to one of the 3 groups. Social case management program lasted for 60 days with the option of extending to 90 if needed, and then outcomes were collected from all 3 groups at 7 days and 90 days post-discharge. So we include in the trial. We did acute ischemic or hemorrhagic stroke patients who were adults and living at home prior to stroke. They had some stroke symptoms on presentation and had to have some evidence of disability at discharge to home. To discharge either directly home or return home within a month of spending time in a rehabilitation facility. And if we're unable to provide consent on their own due to cognitive impairment or stroke-related deficits, then they had to have a proxy available to provide consent for them. And we also enrolled caregivers, and that was basically a person that the patient defined as who would be the primary help once they got home. The patient had to be consented and participating in the study, and the caregiver simply had to be an adult and be able to speak English. And during today's presentation, we're not going to results of caregiver data, but we did collect outcomes on caregivers. So our missed interventions were designed really to provide help with 4 main areas: support, preparedness, unmet needs, and stroke prevention. And with that, through providing emotional support and education, pairing people by providing additional education, helping them with organization skills, problem solving, and communication skills, identify unmet needs and then make appropriate referrals and advocate for patients, and then to help by providing, again, education, stress management techniques, and then support lifestyle modifications, and make sure that they were attending their follow-up services. Case management intervention started when the patient discharged home, and as mentioned, the target was to last 60 days, but that could be extended if needed. It's with a complete biopsychosocial assessment that we tried to do within 3 to 5 days of when people reached home. And this assessment really guided the development of a service plan, which was done in collaboration with the patient and caregiver. And a set of goals were identified, and then specific tasks were help achieve those goals. And we did prioritize safety, patient problems, and follow-up appointments. And the social worker followed up as needed based on the needs of the patient and the service plan to help coordinate services, communicate with providers, provide them practical and emotional support and resources, and referrals that needed to be done. The site intervention was an online information and support resource that was really meant to complement the social work case management program. Was meant to encourage self-management by allowing people to have independent access to information.
Okay, thanks, Michelle. This is Matt Reeves here. I'm going to take over and just talk to you all about the data that we collected, the outcomes data and the primary results, and then I'll get back to Michelle to wrap up. And again, thanks for attending today's webinar. We appreciate that. So the study's primary outcomes were patient-centered outcomes, as is consistent with the PCORI mandate to center care around patient-reported outcomes. So our primary measures is a quality of life measure, as documented by what we call the PROMIS Global 10 measure. There's 2 components, one physical health and one mental health, and a measure called the patient activation measure, which is a validated measure of the degree to which patients are activated. And we also have secondary measures, including depression, measure of anxiety, and the more traditional health services outcomes of readmissions, home time, and stroke or TIA recurrence at 3 days at the end of the trial. Also collected a bunch of other data that we won't be reviewing today, but we have lots of other what we refer to as mediating or moderating variables, including some of the more traditional stroke outcome measures such as modified ranking or activities of daily living Barthel type scores. Analysis, again, we're collecting data both at 7 days and at 90 days with attention to treat analysis, using what we call a difference in differences model, where we first look at the change within each group. So within each treatment group, we're looking at the change over time between the 90-day time point and 7-day time point. And this is the advantage of it accounting explicitly for the baseline starting value. And it also gives an indication of the direction and magnitude of change in the usual care group, which tells about the natural or secular change in these outcomes. After looking at the change within group, we then compare the change within group to within the group. So we're looking now at the change between groups over time. And this is actually what we use to quantify the treatment effect. Again, comparing the change over time or the slope in the treatment group to the usual care group. So looked at some of the other 90-day outcomes, the readmissions and recurrence using standard LOGIS type models. So let's look at the results. The first is just the typical consult flow diagram. Just look at the top here. We screened almost 1,800 patients. We enrolled 320 in the study. Enrolled them at the time that they were discharged from the hospital. We ended up randomizing 265. 55 were excluded primarily because they ended up staying in the rehab facility longer than the 4 weeks. So the 265 were randomized to the 3 groups, 87, 88, and 89, as shown here. This is usual care group, this is case management, and this is the case management plus website group. We had some lost follow-up over the 90-day period, and we collected data at 90 days from 70 participants in usual care, 72 in the Group 2 social work group, and 72 in the website group. Overall, then, we had 240 patients who provided outcomes data on these 7-day or 90-day interviews, which will be the primary source of the data I'll show subsequently. This is the demographics for the 265 randomized patients. It's typical of a stroke population. The average age is about 66. Half of the people are female. 21% of the participants are non-white. Pretty consistent with the demographics in South Michigan. Most patients had mild stroke. 72% had mild stroke. 27% had severe stroke. Just less than half were discharged home directly, and the other 56% were discharged to either an acute or subacute rehab facility. About 2/3 of the patients also had a consented caregiver. This is our Promise Global 10 quality of life measure. 10 questions, analyzes 2 subscales. One is the physical health subscale, which basically measures physical health, physical functioning, pain, or fatigue. And then we have a mental health subscale, which it consists of an overall quality of life question, your mental health, satisfying with social activities, and some emotions. And this is the sort of typical template for this Promise Global 10. Here's a question in general: how would you say your health is? And you rate that as either excellent, very good, good, fair, or poor, and are scored accordingly. And there's 10 questions in this measure. Apologize for the complexity of this slide, since we're not able to use animations to introduce this, but let me just explain what's going on here. On y-axis, we have the score, the Global Physical Health Score. It's standardized to a mean of 50. Mean would be a typical population-based average, and as we can see, this is the 7-day values here for the 3 groups. Blue, usual care, red is social work, and green is the social work plus the website. These are starting 7-day values, and these are the values at 90 days. So we can see that the stroke population started off with a substantially lower global physical health quality of life, substantially lower than the population norm, which is what you'd expect with patients who had just had a stroke. And we can see over time, this is then looking at the change between 7 and 90 days, we see very little change in the usual care group, which is blue, a little bit of an increase in the social work group, which is in the red, and then much bigger increase in the group that got access to the website, that's in green. The bottom line is that increase in slope for the website group was statistically significantly greater than either the usual care group or the social worker only group. So the group 3 who got the website had an improvement in their global physical health as reported by the patients compared to usual care or the social work only group. So that's physical health. Mental health data, and I'm going to skip through these pretty quickly. You'll notice that the scores are a lot closer now to 50 at baseline. There wasn't much change in these values and no differences between the 3 groups. So not much change in mental health over the 90-day period and no differences between the different treatment groups. So no effect on mental health overall. The primary outcome that we looked at, if I can get these slides advanced, is the patient activation measure. It's a 13-item scale that assesses the individual's knowledge, skills, and confidence in managing healthcare. It is a scale of a 0 to 100 with a typical value around 60. These are our patient activation values. They are clustering around this value of 60, which is what a sort of expected population norm is. These are 7-day values for the 3 groups. Again, blue is usual care, red is the social worker group, green is the group that got social worker plus the website. And the bottom line with all of this is that there was, as you can see by this upslope, a significant improvement in PAM, patient activation, in the group that got the website access. So again, this group is reporting a greater increase in patient activation over the 90-day period compared to the other 2 groups. That's sort of concordant with our improvement in global physical health that we saw a couple of slides ago. So I want to quickly go through a couple of other secondary outcomes. These are the changes in depression scores between 7 and 90 days. As you can see, they're almost identical for all 3 groups, so no differences there. This is, if I can get a slide to advance, yes, the NeuroQual anxiety measure. We thought that anxiety would be something that we would see higher in the stroke patients and maybe see a change over time. As you can see, these values cluster around the population average of 50, so we didn't see any significant changes between treatment groups in anxiety. Basically, their anxiety levels were no different from what we'd expect in a population norm. Here's our hospital readmissions. Obviously, there's a lot of interest in these type of programs to reduce readmissions. Here are 90-day readmissions across the 3 groups. They're all clustering around 20% over the 90-day period. And we did not see any significant differences between our 3 treatment groups. This is usual care, this is social work group, and this is the website group. So no difference, unfortunately, in readmissions, and also no difference in stroke recurrence, no significant difference in stroke recurrence between the 3 groups. So no differences there. And these are our slides for something where we're measuring the self-efficacy of the patient's ability to manage their medications, their activities, their emotions, and their social interactions. 50 sort of a population average. And the one significant change we did see here was with this data in this top right-hand corner with managing daily activities. We saw an increase in the website group had a greater ability to manage their daily activities, which we think is sort of concordant with the data on their improvements in global physical health. That's sort of a secondary measure. And then these are perceived support measures tracked over the 3 groups. These values are higher than population norms, which makes sense. We would expect stroke patients to be receiving more support once they get home, and so it's to see that occurring. But we did not see any differences in our intervention between the amount of support patients thought they perceived they were receiving. This is another important outcome, the modified ranking scale. This is used as a traditional outcome measure for many stroke trials. It doesn't look very impressive with the global, with the scale here, but we actually did see a unit improvement in the modified ranking group, in the website group in modified ranking. So the green line had a greater decline over time than either the blue or the red. There was greater improvement in the ranking amongst the website group. Again, it's sort of concordant with that global physical health change that we were seeing earlier. And again, a decline in ranking scores is better. The lower the ranking, the better. So, So just to point about how did event interventions go, let's talk about the social work case management. We were able to start that process in 90% of patients who were assigned to groups 2 and 3 who were receiving the case management program. We found that at the baseline after the first assessment that the mean number of unmet needs was about 4.5. The most common unmet needs were need for stroke education in 3/4, health finances, other healthcare conditions, and mental health in about 1 in 5. The study interacted either in person or by phone, or by messages at least 3.5 times a week. And the duration of our case management program lasted 55 days, which was as we had planned. 9 cases had their social worker case management extended up to the full 90 days. So the case management intervention went well as planned. The MIST website, though, is an interesting anomaly in the sense that we were able to train 80 of the 90 participants who were assigned to Group 3 to access and use the website. So they got the social worker trained them on how to access the website at home. And we tracked the utilization of the website using a Google Analytics program, which works sort of passively in the background of the website. Interestingly, we found that only about 1/3 of the people who were trained to use the website actually used it on their own. The use was fairly limited. They only accessed an average of 3.3 days. And the total page views, the number of different pages they looked at was 25, but with quite a wide range. So despite the fact that we saw a significant change to the website group, the actual utilization of the website, at least as we were able to document using the Google Analytics was quite limited, and was trying to figure out why we saw the data that we did, given that the utilization was what we would consider fairly limited, certainly not as high as we would have hoped. To summarize, access to both the social work case management in combination with this informational website, the MIST website or VIS group, resulted in better quality of life, as reported by physical health, improved patient activation, improved self-efficacy in managing daily activities, and improvement in the modified ranking. And these results are all statistically significant and would sort of characterize them as sort of being modest in size. Definite improvements, but none of these patients could be regarded as being cured by any of these interventions, but definite improvement in all of these patient-reported outcome measures that we think are important to stroke patients' recovery. So I'm going to turn it over to Michelle to just wrap up on a few slides, and then we'll have a few minutes for questions.
So in some of the previous slides, we collected a whole lot of data, and we are in the process of analyzing some of that. So there's still many secondary or post-hoc analyses to do. Some of that around understanding how the social work case management program was actually delivered. We have activity logs that were maintained by the social workers for each patient that are detailed. There's both some qualitative and quantitative work that we plan to do around that. We also want to understand the VISP use and why we achieved the positive results that we did despite, as Dr. Reeves said, the low utilization rates. We did implement post-study qualitative interviews, and we have those from about 25 members from this group that we plan to analyze just to help us understand what the potential barriers or what they would consider success around the website. So some is still learning how stroke survivors and caregivers view successful access to information. And then we have mediation and moderating analyses to do to help us understand what might be driving our results and whether the results are more positive in certain subpopulations of our study population. I mentioned we also collected outcomes from caregivers, and we are analyzing those. And we also collected relationship scales with both patients and caregivers to understand how the stroke event and the recovery process impacted their relationships. The work to do. To share some of that in the future with you. So just in terms of reflections and then some resources that we have available at the moment, the bottom line is we know, as you know, patients and caregivers still need help. Provide in-home services. There's still a lot to learn around. Individualize that for patients and caregivers to have the most effect. And so bottom line is we still have a lot to learn, a lot of work left to do. Some of the observations that our social workers had from the field, some of the challenges that they had is they were able to identify needs, but as we know, resources are scarce, and there's a wide variety depending on what community you're working with. And so there's a gap in terms of even if we identify needs from an institution standpoint, it can be difficult to know what that patient or survivor has access to in their own community, since we're visiting patients from multiple different communities. So the thing that needs to be continued to be advocated for are community-based resources. We also found that patients and their caregivers have a large array of unmet needs, and many of those are not medical. So the issues around financial strain and just helping people and providing assistance with them with appropriate resources is an area of need. There's quite a bit of mental health unmet need that's out there. Of course, there's need around different medical comorbidities. In addition, we also saw that people had housing needs, and that might include home repairs or modifications that are needed in relation to their disability, and resource for that. And then, as we know, there's a need for continued stroke education and communication support throughout the continuum of recovery. And that involves connecting people to services and healthcare providers over the course of the long term of their recovery, facilitating services, and then providing for patients to help advocate for themselves. So from the social workers is that stroke is not just a medical crisis, and again, there's lots of hard work left to do. So as part of our dissemination efforts, we have a website that's listed here, mist.edu, that has a series of fact sheets that we developed in conjunction with our advisory board to help just communicate and prepare people for when they go home, and also to give them some resources. So you're welcome to visit the website, click the fact sheets link, and you'll find a fact sheet that gives a short summary about the study. Focuses on things to know when you return home after stroke, and that focuses on communicating with your healthcare team, and that focuses on stroke and stroke recovery and finances and financial resources. Process of working on a fact sheet to help inform healthcare professionals, and then one that will be targeted specific to caregivers. Also some informational videos that were produced, again, with the help of our advisory board and some of our MIST participants that just help talk about what to expect and when you go home and during the recovery phase. We have a list of resources that we left in the Lansing and Ann Arbor area, and at some point we would like to release some of the material we have on the MIST website for people to use. And then a list of our academic and professional presentations and publications on that site, so you're welcome to use that in practice. And then there are just two of the papers that we have published at the moment. The study protocol is published, and then we've also published a development and implementation of the social work case management intervention, in case you're interested in some of the details of that program and how they were developed, again with stakeholder input. So I'd like to acknowledge first and foremost the stroke survivors and caregiver participants in the study, and our MIST advisory board members, and then of course our recruitment staff and the other staff at the hospitals that help support this project. There was a lot of hard work that went into getting this project done, and so we want to thank our social work case management staff, our data collection staff, the folks that helped with technology and creative support, the people that help us manage and analyze our data, and then, of course, to our co-investigators. We're happy to take any follow-up questions, and you're welcome to contact us by phone or email as listed here. Thank you for your time today.
And Dr. Reeves for addressing our group on your MIST study. Really an amazing project, and I think it's going to have a lot of implications for our webinar participants. And we really appreciate both of you taking time out of your day to share with us the results that you've been seeing. I'm going to briefly turn it back over to Renee to go over just a couple of things, and then she's going to let us know when the floor is open for questions for our webinar participants.
And again, thank you so much, Michelle and Dr. Reeves. This work that you're doing, it really complements our work in quality and systems improvement. We focused on the stroke system of care and approaching that from a health equity and patient-centered perspective. So again, I think this work is really important, and we look forward to seeing your continued results. So very quickly, because I want to open up the floor for questions in just a few minutes. At the end of your slide deck, we have links to a few upcoming events. We do have I wanted to point out our AFib virtual conference, February 27th. That will be a free conference that you can access directly from your computer. So please, the information for registration there. And then moving forward, these are a few additional stroke resources. And the last one on the right-hand column is our stroke rehab toolkit. Please take a moment to review these links. Again, everyone who registered would have received these slides in your reminder email, and we'll send the slides out again later this week. Additional AFib resources and team quality and systems improvement. We focus on several disease areas, including, of course, stroke, and also AFib, coronary artery disease, resuscitation, and heart failure. And all of our team would love to speak with you a bit more about AFib and the relationship between AFib and stroke, if that's something that your team would like to hear a bit more about. And a screenshot of all the different resources that we offer. A list of our quality and systems improvement team in the Midwest. These are all of your stroke contacts. And I want to take a moment to introduce our new director in Wisconsin, Susan Abel. This is her third day on the job, so welcome, Susan. And feel free to reach out to your local director and also let Kathy or I know if you are under contact. I'd like to open the floor for questions, so our auditor will provide instructions for asking a question. Thank you.
We will begin the question and answer session. Participants over the phone, if you would like to ask a question, please press star followed by the number 1. Unmute your phone and record your name clearly when prompted. Name is required to introduce your question. To cancel request, please press star 2. 1, please, for the questions to queue.
So I actually got one. Oh, sorry, I actually got one via email for Dr. Reeves and Michelle. Do you have a time frame as to when your results for caregivers are going to be available?
So the results I presented today are patient whatever results. We didn't present any caregiver results. We're trying to get the patient results out first, since there's a lot of background information about the trial, and then caregiver results will come out. So I'm guessing by now, probably officially, the caregiver results will probably be out in the spring or early summer. That'd be my hope. We've also got an extensive array of analyses planned to look at what we call the dyad analysis, where we look at both patient and caregiver combined. So we're working on that right now. So bottom line is, I'd say another 4 to 6 months before we can release the caregiver results.
One question pop up in the chat box, and it says, did the SWCMs compass practice interventions overall?
So the social work case management worked off of best practices out of social work, and we work with our local stroke coordinators and stroke programs to tailor that to stroke care specifically. They were guided largely by some of the guidelines that were put out by AHA or ASA and the National Stroke Association. I'm not sure if that exactly answered the question.
The BPA is a sort of a standard form.
In the biopsychosocial assessment that we did is a standard form that is used in social work. It was tailored a little bit so that way we could ask some stroke-specific questions, particularly, tailored towards like stroke deficit, that sort of thing. But that has, I think, multiple, 8 sections that covers everything from housing and social support to medical conditions, finances and income stability, and then any mental health and addiction challenges people might be facing. And there's a summary at the end of that the social worker is able to rate the strengths and weaknesses in each of the different categories, and that's used to help identify needs and basically guide that service plan. We are working on analyses right now about the specifics of the BPSA or the biopsychosocial assessment. Also looking at, are there certain patient level factors that we to predict how much need people might be having once they go home. And so we need to have those out as well in the next 4 to 6 months. But lots of interesting things to learn around that.
Did any questions come in through the line?
As speakers, we don't have any questions in queue. Again, participants, if you would like to ask a question, please press *1.
Well, I have a 2-part question. The first would be, was this study implemented in other parts of the country? And then secondly, moving forward, do you see this as something that that other hospitals, other regions can implement locally?
Yeah. So first, it hasn't been implemented anywhere else, and I think like all research projects, there's been basically little done in the area of transitions, and I think we need to do similar studies and replicate them to understand what works and how. I do think an active case management program is probably one solution to transitions, and whether it should be just social work only or a combination of social work and maybe nurse-led might be a better approach. And the idea of using this website is obviously, is that something that's readily transferable and implementable across the country, So I think as we figure out with more detail about what worked and how to implement this more efficiently, I think obviously the end game is that we would have this program freely available to everyone. That it really be a sort of a standard of care. But the question is, can we really afford to send social workers out to the home of every stroke patient? Probably not, but maybe there's a subgroup of stroke patients who would benefit more. We haven't showed data on this today, but there's some indications that patients who go to a rehab facility first, more gain out of this program than patients who went home. So this is the concept of risk stratification. I think we can refine who really needs the direct help. And hope is eventually, through technology, whether it's web-based or phone-based apps, and also some human touch, some sort of some case management programs that we could have a transition care program is no different from the in-hospital care program. I mean, you simply get discharged and then you enter into sort of a more active case management care plan through the transitions. But a long-winded answer, but I think we need more evidence to figure out what is a cost-effective model that insurers and others would be willing to pay for.
And this is developed off of the work that CMS was doing with their bridge care coordinators, modified based off of stakeholder input. But so you can look up some information about the success of those programs, and those programs are certainly implemented across the nation, but they largely don't include stroke patients. They're targeted much more towards heart failure patients and chronic renal disease and others where you see some of the bundled payments coming in. So still a lot of work to do to understand the specific needs around stroke and how to maximize around that.
And the comment I would make is, people are motivated to pay for these type of programs if it can reduce readmissions, and unfortunately we didn't reduce readmissions. Got improvements in patient-reported outcomes, but it's going to be more of a challenge for us to convince people to implement these programs because it didn't reduce readmissions. However, there's very few programs, if any, that do. So that's just a big challenge, but obviously it's the one that hospital systems care about the most.
Well, great, and thank you both for joining our webinar today and presenting this important information. We look forward to continuing to follow the dissemination and sharing that with our group. Are there any further questions? So we can go ahead and close today's webinar. Again, thank you all for joining, and we will be in touch with a few follow-up materials. Have a wonderful day.
That concludes today's conference. Thank you, everyone, for participating. You may now disconnect.